Ruth, thank you very much for a difficult job in moderating a very complex panel discussion. Very much appreciated. And the panel, thank you very much for all your insights. So we come to an interesting part of the day where we will go around the roundtable and just ask for a sentence or two, since we want to finish reasonably on time, since we have a working opportunity later on in the day. Just a sentence or two as to what your reflections are from the sessions we've had since 8:30 this morning. And I'm sure they'll be very insightful, but I would hope that you keep that to a sentence or two so we can go through the entire roundtable. And I'm going to start with Michael on the right-hand side and then go around from there.
Thanks, Bernie. I think today really showed one of the more knotty and really visceral and present issues that we have in health literacy, because this is something that really touches upon everybody, and this issue of health insurance literacy and being able to navigate the system is so remarkably complex. One of the things that our organization is a navigator, and we work in a community-based setting, and I think given all the existing situations and rules and regulations, I think the solutions really lie within the community. And I think we saw a lot of that in the presentations today. Barring just simplifying, flat out simplifying the system, I think the solutions to helping people navigate through are based within the community and the people who know those people the best. And there was a comment about following up with people after they're enrolled. That is absolutely critical. We have been advocating that for years. We've been talking about that for years. We've developed programs and tools for that. But I think that's really where the emphasis needs to be, and to the extent that those people who work with individuals after they've been enrolled on how to use the system more appropriately, to the extent they can be rewarded or incentivized to do that, I would strongly advocate for that.
I was really impressed with the sort of just-in-time approach, and it reminded me of some of the work Jim McCroskey did in communication that could really inform some of this work in terms of selection, apportionment, and arrangement of material. I think we've got a tendency to put things in the order that we think that they need to be in. And I think that there's some dramatic, and some of the discussion about the usability sort of conjured this too, which is that we need to figure out what to put at the top, basically. And also a series of the right questions. In other words, questions like, are you regularly employed? In other words, or are you a seasonal worker? Or have you a major debt? Or things that will trigger understanding where someone is. Those may not be the most sensitive questions, but the kind of thing. And to figure out what somebody really needs to get the flow of what we're trying to get them to kind of get to the point. And the other piece is we seem to be defogging things that come to us in fog. And probably the easiest cry would be, and I know Ruth said this earlier in time, but transparency from the sources. In other words, we're trying to tease apart numbers and algorithms that are presented to us as an end product. And the more that we can collaborate with the institutions, I think, the more we're going to have a demystification of the process. So those were the two takeaways.
So Steve Rush, United Health Group. Today was a very, very rich day for me. I took a look at health insurance literacy as kind of like the intersection of health literacy and financial literacy, and where there was overlap, that's a very big area, and it's complex from both the financial literacy as well as health literacy. A couple of things that I took was, and I will use them as I'm working within my organization. I'm taking away that health insurance literacy and health care is a learned behavior. And that's very powerful. It is for me, and when taking a look at how an organization creates services and programs, how understandable is the information? How usable is the information? How much work, how much cognitive burden is there? And the question then is, to what extent can we lessen the cognitive burden associated with illness and treatment? So that's one of the things that I'm going to take away. The other concept that I'm going to take away is 3 words, and Katina used them. What are the skills and issues needed to get insurance? What are the skills and issues needed to keep insurance? And then what's the skills and abilities needed to use insurance? And that's really a great, from me, from my standpoint, it's a really great framework. And when working with people within my organization who are communicating with consumers, with members, who are creating products and services, those 3 things resonate really well. And I thought today's program was absolutely tremendous. Thank you.
Rima Rudd, the Harvard Chan School of Public Health. I was really very impressed and buoyed by what I felt was a sincere focus on assistance with dignity, with clarity, through trust, transparency, with a really sincere effort involved in removing barriers. And some of the techniques that were offered were really very, some of them very old and well-known techniques, you know, really piloting the rigor of formative research, task analysis. Now, all of this is very good and very important, but it seems to me that it's still working downstream. So rather than, there's a part of me that was beginning to celebrate after one and after another person talked about piloting an effort in very creative programs, talked about the formative research that went into it. But there's a part of me that thinks that that should not lead to an A+ grade. That should be the basic C grade. That should be the basis of what you're doing, not something to celebrate. So we have to insist on rigorous formative research. We have to insist on rigorous scientific approach to these problems, because it seemed to me that we're taking it for granted, almost, the absurd tools that we're offering people, the outrageous expectations that we have that people are going to carry through with arduous tasks, and we're busy fixing it. I mean, it almost reminds me of careful, sincere mechanics being charged to work with a machine. It's a money-making machine, but they're charged to explain the machine, teach people how to use the machine, fix parts of the machine when it's broken, rather than step back and as a union say, we're not working with this machine anymore. We're going to fix it entirely. We're going to change it. We're going to throw it out. So this constant fixing and such sincere efforts going into an effort that is just overwhelming, overwhelming. Teach people how to use a flawed system. Let's change the system. But I mean, there were things to celebrate. There were definite things to celebrate. And I learned a great deal, and I was just so very impressed by some of the wonderfully creative programs that were described.
Ernestine Wallace at the Medical College of Wisconsin. I also felt really invigorated by today's exchange of knowledge. I think we have to somewhat acknowledge that we've seen more people insured. I think the customer component of it is refreshing to hear and know that we're making progress in that arena. But I also know there are great, great needs, and I think I'm sort of coming at it where Rima was talking about. We have many flawed entities that we must face up to and have a discussion about. I was disappointed, and I think I told Katina here, where we should have a system that is absolutely based on consumer satisfaction and consumer being able to benefit from it. We have a system that really is based on, it's still driven by money and cost. So I think that's something that we have to, we didn't get into that, and we know that that exists. But I also know that we need more knowledge to be health literacy and health insurance literacy. when we got into talking about, today we spent a lot of time really talking about the exchange and the complexity of the exchange. But when I think about the life course and what we're asking the navigators to master, if you start out from CHIP right through the complexity of CHIP, which varies by state, right through to Medicaid, which varies by state, employer-based services varies, exchange varies, Medicare has its supplements that varies, and then the military. So when I go through and say that's the life course of insurance, it requires a very sophisticated knowledge base for us all to be part of it. So I come to the conclusion that we all have to change our behavior. The institutions, the plans, health plans, the end users, we all have to really explore the different sectors having a true ownership of this process and do a better job of saying we all need to focus our health literacy, including providers, which I'm a part of.
Terry Davis, LSU Medical Center, Shreveport. The themes to me were trusted personal health will continue to be essential for many. Many people will need ongoing health. Talked about the boomerang effect. Situations change. A one-size-fits-all probably won't work. And just as I put this in the context, as a country, we are all learning more about health insurance, and I see this as a part of the dynamic changes going on in healthcare. And at the Aspen Institute, there was this huge thing about the world is into cultural changes if we move from an agrarian to an industrial to an IT global society. And I think this health insurance is a part of it. It's, now that's a part of patient responsibility, provider responsibility, and it was not in the forefront before. Also, just personally, people I hear a lot of at home about the cost of health insurance, but nobody talks about the cost of care. And I guess because they just have no clue. They know what health insurance costs.
Lindsay?
I agree. It was a wonderful day. I enjoyed all the presentations and learned so much. From my perspective, Sue Bakken, Columbia University, from my perspective as an informatician, I was thinking a lot about the ways to decrease task complexity, not only in terms of the consumers, but also thinking about the types of tools needed for the assisters, because I think that the task complexity needs to be decreased on both ends.
You're so efficient. I'm less efficient, Alicia Fernandez, UCSF from the Roundtable. I had 4 points, less efficiently. The first is that I learned a lot, and I thought that was really wonderful. At the same time, and it may just be me because I'm a salaried physician seeing an extremely vulnerable population, there are still aspects of this that I just don't understand. So for example, I really don't understand why an insurer would want to offer 26 plans. I don't understand the market logic of that, and I don't understand why that isn't at some point self-defeating, and I wish I could understand that better, because that's clearly part of the problem. The second issue is that it would, and again, this may speak to my issues, but I think it would have been, I really liked the presentations. I still feel a little bit of need for a little bit more data on the characteristics of the 30 million uninsured, particularly because my understanding is that, and I think I'm coming off of a Kaiser Family Fund brief, I don't know if they're still here, that I saw, that says that among the Latino uninsured, which continue to be the majority, continue to be the largest ethnic group uninsured, that 80% of those folks are LEP. And I think putting that if that fact is true, and I would like that verified, that needs to be highlighted in a way that could easily get lost among all the complexity. The third issue for me is around the roundtable, and the roundtable, I'm not saying that we are making recommendations, but were we to make recommendations, I think that from my perspective, I gained some clarity around what those would be, and I would see two. One is the need for ongoing assisters for the highly vulnerable, who are, it's just not going to happen. But second, the need for us to push for a more health literate insurance system using many of the same best practices that we learned today around using standardized health plans, using consumer report type nudges, experimenting with other forms of default. And I think that the high degree of variability between the states and what they're allowed to do and in what they have chosen to do would allow for a synthesis of that. And the last plea, and I know I'm taking a long time, Bernie, is that I do think more research is needed. And I think here it would be fantastic if there would be a way to experiment, for example, with in one state changing the enrollment deadline to coincide with April 15th. And to see what that would do. Or looking at the impact of high deductible insurance plans and physician transparency on choice of drugs. I think that is patient-centered outcomes research. And I, for one, find, as a member of the Board of Governors of PCORI, have found this extraordinarily stimulating in terms of what sorts of research can and should be done.
Jay?
Jay Duig, AbbVie. I don't think that the roundtable authors are going to capture this. It'll be too on the nose for them. But I'm struck by it, and like to comment on, throughout today's discussions, the applicability of the recent roundtable paper on the considerations for a new definition of health literacy, and then how in working through the different the components that are outlined in that with the multi-dimensionality, so a focus on system demands, outcomes, the potential for change and informed decision and action, that's really what we're talking about today. And I had the opportunity to be at a separate conference yesterday on informed consent, and also having a high degree of applicability, so in the same way. So I think that that's great, because we're looking at a consideration of health literacy issues that are so found throughout our system, and have a solutions and an outcomes-based approach. So, and my hope is that that conceptualization will continue to gain traction, so that stakeholders throughout the process will understand that these problems are not intractable, and that there are things we can do to continue to get better. Thank you.
Cindy?
Yeah, I'm going to talk about the day in somewhat different terms, because I saw a lot of this as a clash of different values. And so on one hand, we have a cherished value of choice and of the free market. And, to Alicia's point of why would you have 26 plans? Well, people want different things, and they should be able to choose. And we're very hesitant to infringe on that. On the other hand, I heard today, a plea for simplification. I heard some paternalism in terms of, we can point them in the right direction. And so there's this tension. And so to me, the navigators are parachuting in to try and mediate that tension. But I feel very similar, I think, to Rima in terms of it's kind of putting a Band-Aid over a open, gaping chest cavity, that it's just, this is really a mess, and so we're trying to do these little things to make it somewhat more manageable. So my thoughts in terms of, tomorrow's discussion and thinking forward is about the future of navigators. And today we've only talked about health insurance navigators, but there are other kinds of navigators in the healthcare system. There are cancer care navigators. There are community health lay workers who essentially serve as navigators for various communities. And I think that there is a real danger that these people who I heard today are playing a much larger role of navigation than just that enrollment process might go away once, we get a little further in terms of our goals for enrollment. I also didn't hear anybody today talk about the fact that we are not going to get 100% of individuals enrolled in health plans. I didn't hear anything about the undocumented, and while that wasn't the focus of this discussion, I worry that as we sort of talk as if everybody is going to get health insurance, eventually we will reach them and enroll them, that is kind of not being addressed. And my final comment is also somewhat in response to Alicia's comment, which is that ARC a number of years ago funded Glenn Flores in some work that did a study that you'll just be amazed to find out that when Spanish speakers were provided with bilingual care workers, that they were much more likely to maintain their insurance. So, we know that people fall in and out of insurance, and so I think we really need to be thinking about what the longer-term strategy is after enrollment as well.
Katina, I passed you by, so that I'm going to bring you back.
Thanks. It's interesting to think about all these things today, kind of contextually with a bunch of other people who don't do health insurance work all the time, because that's much of what we do at HLM all the time. So we have folks that spend their entire working day doing this work, and then we work with the coalition that are doing the same thing. And so, it's interesting to hear the other thoughts about where we are and what we should be doing, because I'm so kind of stuck in the middle of it that I don't necessarily see all the things that other people see. So I think it's really important to hear those things. But the other really interesting thing to me is across all of these conversations, the salient points are so kind of heavy and consistent and salient across the talks. And so this kind of navigator model, direct care, like how do we talk to people? What do they want? What are the values? Those things are really big themes that, you would have to, I don't know what you would have had to do to miss that today. It was so big and bright in the conversation. And so it's nice to have a really clear direction and a really clear kind of idea that although there are problems, we're all kind of standing in one place and understanding things largely the same. And it's not like we failed to include the voices closest to the consumers on the street. So we obviously didn't have real people here that were uninsured, which would have been inappropriate, but we've got the people that are standing right next to them, holding their hands, talking about what they need and what the services are. So I feel like we got a good picture of that, and there's a nice understanding of where to go next.
Michael?
I guess I'm struck that we created an extension of the healthcare system without the tools, without adequate training, and it feels awfully cynical to just have this kind of supportive resource, but as meager as it is, and then have it go away once you're enrolled and not have other support. And also have observed in some places that some of the navigator systems are set up as a way to bring people in at a much lower price point, as a way to get rid of union jobs, as a way to basically undermine the whole field of social work. And so there's a whole kind of phenomenon that I think is part of the conversation that has to kind of be re-envisioned. What is the training that we want for someone to have to interact with patients about complicated topics? And this is true at multiple levels. There's the decision-making part of the communication. There's understanding all this stuff. And at least from the perspective of health literacy, we should be, I feel like it's easy for me to advocate for more training and communication, for more linguistic access, for more of all of this, and that it's not just going to go away now that people are enrolled. That's a cynical way to say that Obamacare has failed, because once you enroll people and then they can't use it, well, of course, it's not going to work. So I think the vision for, if you want to design a system for success, It will require a big effort just not to bring people in, not only to bring people in, but to support the cultural transformation that it takes to use insurance in a pro-health way.
So we won't have a discussion about that. These are reflections on the day, but can I call those innovative solutions? Just yes or no? Yes. Thank you. Winston?
Well, I'm going to probably counterbalance some of Michael's comments. To the authors of the people that passed the Affordable Care Act, I do believe the passage of the Affordable Care Act was a step forward for health literacy. I think there's 20 million Americans that have insurance, and whether that insurance is Byzantine and difficult to navigate, it actually at least presents the issues with regards to which health literacy becomes operable. Secondly, I think having said that, the Affordable Care Act exemplifies the value that we now embrace in America. Not that health care is a right, but the right to purchase health care is a right, which is a big difference. Now, I think our discussion today was really focused on two areas. One was the impact of health literacy in basically transactional issues with regards to getting people enrolled and then subsequently utilizing and leveraging what is in healthcare coverage. The other part, which I don't think we actually spent as much time in, but was actually touched upon, but perhaps not so explicitly, but these are the themes that Rima and Alicia and Cindy kind of touched upon, is health literacy in a population-based approach relative to healthcare coverage, i.e., what is the operative element of health literacy in terms of reaching out to communities so they understand what their right is, dare say their obligation is, to be insured, and what it means to be covered under health insurance. That's a population-based question, not a transactional question. It's a political question. And I think the reason why navigators become so intriguing is because they actually bridge the transactional and the political with regards to health literacy. But I think there's much more work that needs to be done relative to looking at the navigator and also producing the population-based health literacy relative to healthcare insurance coverage.
Terry?
No, I too thought today was a great day. The innovative solutions or pilots this afternoon I thought were just great. The themes that I heard were community, partnerships, respect, trust, meeting people where they're at, providing what they need at the right time. And, that requires a hybrid approach with, multiple touches. And I think the main concepts that I heard, and terms that I really hadn't thought much about, were the coverage to care concept. We all hear and focus on getting people enrolled, but that whole concept, separate from the navigators. And the term nudges, I still struggle a little with that. I think done well and done, correctly could be and has proven to be very successful and positive, but I think we need to be very cautious about how we nudge people, because those decisions are very personal and value-based, and I think there can be bias there. So that it just makes me uncomfortable sometimes talking about those nudges. So just
good. Kim?
Hi, Kim Parson. And Terry, I won't elaborate, but I will say yes, those nudges make me uncomfortable as well, as does limiting my choices. So what a great day, and I love the examples and the best practices that we heard, and of course, because we had someone in the room talking about consumer-centered design and the importance of involving the consumer at the center of all we do. I thought that was the best part of the day. I guess what I would say is, when we talk about health insurance literacy, and we're talking about it today, or maybe we've been brought together today to talk about it because of the ACA, and we have so many more people who are now navigating this or whatever. But all of these challenges, everything that we're talking about, they're not new. They're not new challenges. They exist for all of us, whether we're on Medicaid, Medicare, whether we're on a commercial group plan. Whatever. It's a very complicated system. Insurance is complicated because health care is complicated. A gallbladder is not a gallbladder is not a gallbladder, right? Everybody's experience with having that removed and where it's removed, what system, et cetera, can be such a wide range of experiences. So lots of challenges, some of them not new. But encouraged by the discussion today, and always at involving the consumer, having the consumer be the driver of the partnerships and the efforts that we will take to try to solve these problems.
Mary Lynn?
Yes, Mary Lynn Ostrowski. I think I'll touch on 2 points. One is the transparency issue, and helping people understand that a lot of the complications in transparency are actually driven by health plan contracting, and how they go about contracting for services. If they're buying bunches of services, if they're buying specific services, are they doing a total knee, total hip, whatever that is, and then which ICD-9 code and which revenue code is going to get attached to that. And so if we want the consumers to be able to find out how much that is going to cost, they need to, the doctors then need to know what the revenue codes are and what the ICD-9 or the ICD-10 code is now, which there's thousands of them. And all of that comes in through the contracting process. So if we could simplify the contracting process, it would make transparency a much easier goal that we could actually achieve. So I did want to talk about that. And then I also wanted to mention, we talked a little bit about who's missing. The health plans are missing from the discussion. They know the problems. Kim works in one, I work in one, we know the problems. We hear about them every day through our members, through the complaints and the appeals systems, and how do we solve for those. And we do have an appetite to work on that. I also heard an appetite to share best practices across, and creating some platform to create that. And then going back to, I forgot on who's missing, the community is missing. So when we look at the community, health is so much more than health care, and health starts at home. Health is very, very localized for people, and it's really the social determinants of health that's driving poor health outcomes. So when we're talking about prevention, we need to move into the communities. We need to talk about and look at the environmental, social, financial, economic factors, transportation, affordable housing, access to living wage, access to fresh fruits and vegetables, and it needs to start there. So should we start education, and should health literacy be part of our educational system?
Linda?
Well, I found what I think was like a sister approach today in the notion of user-centered design. And I've always felt a little bit that health literacy is like a straitjacket in some ways. It seems narrow, but we mean so much more. And the notion of kind of understanding better about how health literacy and user-centered design work together to accomplish some of the things that we want to accomplish was encouraging to me. And I would love to see ways that we could engage with those guys a little bit more. And specifically, what occurred to me was one of the things that is a principle of the design approach is universal design. It's kind of a cousin to universal precautions approach. But it seemed to me that this 30 million people that we have left who are the hardest to reach, the hardest to engage, could really be a way to test that universal design, universal precautions approach. Just if we could understand how to reach them and engage them successfully, we would have cracked a nut there that maybe we could be applied to other people. The other thing, and this is a confession that I learned about sisters, is that all this time, I thought we were talking about sisters, but it was us sisters. So, now I know.
Jennifer? Jennifer?
So I don't really know how I'm going to say this, but oh, Jennifer Dillahay. Okay. So I think the thing that came through to me today that seemed so fundamentally pervasive was the importance of caring whether people really understood or not. So all the assisters, all of those things wouldn't even have been invented or come up if we didn't care whether people understood. So then you back up, and it seems like we still struggle in systems and policymakers in much the same way that we do in the health system, of kind of getting it that people don't understand, and that's like a news flash to a lot of people and policymakers, that they don't understand that people don't understand. And it just the whole thing today just kind of hit home with me that we will not have a successful health system unless we truly, all of us, care that people understand, and we make that the, part of the measure of what we do to look at success and quality. And I mean, that's all kind of in emotional terms, but there's really hard ways of measuring that in terms of outcomes and data and so forth. So,
Lindsay?
Lindsay Robinson, American Dental Association. First of all, I just wanted to mention, I feel compelled to mention this, that I kept imagining another chair up there where there was somebody speaking and advocating or helping us understand the issue around dental insurance.
Around what? I missed that last word, around?
Dental insurance. Because the pediatric oral health is a mandate. It's an essential health benefit. Unfortunately, adults were left out, and I think that's a part of the problem. And I think part of the problem rests with the dental profession itself and not really fully embracing a greater role in the healthcare system. I believe that's really changing as we educate dentists. Our early career dentists are now used to working as a healthcare partner with their in a team, in a multidisciplinary team type of environment more and more. So I think it's going to change, but it's going to be slow to change. I also wanted to talk about the issue that came up, a topic that came up over and over again, and that's the idea of affordability. Because the Covered California just recently released the new rates, and the rates are going to, the premiums for for health insurance are going to be going up on average of 13%. Previously, it had been about 4% a year increase. That's significant, and I think, and this was Mila's point. She really was talking about the need to look at affordability of the premium itself. And when you look at the characteristics of the almost 32 million uninsured, and Ruth has the article, looking at this table too about the characteristics, to me what leaps out is that almost half of them are Caucasian. The next largest segment are Hispanics, which are almost 11 million. But over the pervasive issue here, I think, is the fact that there are almost half of them are under 200% FPL, federal poverty level. So these are people who are primarily Caucasian who just can't afford it. Hispanics who just can't afford it. And whether or not they're in states where they didn't expand Medicaid or not, I don't know. I haven't read the whole article, but I think we need to really that's something we're going to really have to grapple with in the future.
Ruth?
So Ruth Parker, so the main thing I really focused on was this, and it builds on a couple of things that have already been said, but really looking at tools to address the complexity of health insurance. And I think we still have gaps in some of the essential information for making informed choice, and I think they center around transparency and quality data, performance data, and cost. And I think until we have reliable data that's transparent about quality, performance, and cost, and we make those a part of everyday tools that people have for making informed choices, we're going to keep coming up short until we have those. It's good that we're making progress, but there's still a lot more that needs to happen there. And so I see that as really an essential area. And when I think about that, I can't help but think that there are just too many secrets.
Stacy? We'll have to talk about over a glass of wine. Stacy?
Yeah, I have to go after that remark. It's scary. I'm Stacy Rosen from Northwell in New York. I thought today was extraordinary. I particularly love the use of the term learned process. I left New York really early this morning. I found a note on my kitchen table from my 24-year-old son. I'm going to a new ophthalmologist. Where's all the stuff? And I'm assuming the stuff meant his insurance card and any of the other things. The stuff. 24 years old, investment banker. I mean, so learn processes. He lives in a house with a doctor mother, and you know about the language and the copay, and I left him, the info about the stuff. I'm the person who said to Lindsay and Ruth that I go from being extraordinarily proud and optimistic to be catatonically depressed. So I started the day I was impressed with the entire day, but I was so excited about the respectful, brilliant approach to this challenge. I mean, even the remarks about the fact that this really needs to be a trusted relationship. This isn't just tell me what size shoes you wear and what your color. This is sexual relations and tobacco use. And I was so proud of us as a community for taking on the importance of this. But then the catatonia came in when the utter mess that this is. And I think the utter mess is a complete lack of transparency and the complexity of this. And my frustration as a practitioner comes on to my inability to do this right as a deliverer of care. And I think that was the voice that I heard the least about today, honestly. And it almost does reflect the way we approached health literacy over the last, decade and a half. It went from being the way the consumer interacts, a skill set that they need to bring to our table, to a bi-directional approach. And I think, to me, we need to evolve today's discussion to really make it an expected competency of the deliverers of care. I practice a very expensive, very procedurally based field. I'm a cardiologist. Our academic world has done a lovely job in guidelines and best practice and appropriateness criteria, even when we can, cost-effective criteria. But when a patient comes to me and asks me, how much does the nuclear stress test cost comparison to a routine stress test, and is it worth it? I am completely unable 15 times a day to answer that question. I have no idea what things cost. I have no idea what it's worth to a patient, you know, before we get to affordability and things like that. And I really think as we fix this, you know, mess of a system, we really need to make it an expectation that the deliverers of care will be involved, will be expected to be educated. It will be a competency in medical schools and allied health professions and PharmD programs, et cetera.
Jim? Give us a gem.
All right. So I'm glad that I'm not the only one who hears sisters. A friend of mine who isn't a sister, I would always repeat back to her that, well, what about your brothers? Thanks, Linda. So I wanted to first compliment and thank Katina for modeling health literate and plain language behavior with the slide that said get, keep, and use. That struck out to me as, you know, eminently understandable. And so I have some new vocabulary if I'm talking to people about what all this is. It occurred to me today that in some ways we're talking about training our sales force with all of the insinuations about, you know, the marketplace and private, the way that we do healthcare in the U.S. And that we're asking a lot of this group of people, whether they're called navigators or assisters, or outreach people or whatever. And certainly we need to make that investment, but similar, I think, to Rima and to Cindy's point, these folks sort of are downstream or midstream, and they're caught sort of in between a lot of different forces. So, that's leaving them adrift in a lot of different ways. So, that last conversation about sort of investment, yes, we do need this investment, because otherwise, we've built a system that no one's going to get to. But at the same time, I think there are still there's a lot of need and opportunity for some other fundamental changes.
So, sometimes I get to say the last word. It doesn't happen at home, but it happens here. So let me just say first that what I'm going to say is going to be no more insightful than what I've heard, but I'll try not to repeat some of the comments I've already heard. Number one, I love the interaction amongst the roundtable. It seems to me that we can agree to sometimes disagree, but still come up with solutions that are productive for the day's activity. So that's a terrific opportunity, and I compliment the roundtable on that. Secondly, let me just think of a sentence that perhaps could frame what we've all said, and perhaps that could be the beginning of how we look upon the day. Let me just state that the triple aim as defined by HHS, that is better care, improving the health of the community and the population, and affordable care, cannot be achieved without the innovative solutions that we heard today that embed health literacy in all its principles and the element of trust. It seems to me that that overarching thought is something that we can put as a theme for what we heard today. And where the focus of all the activity is the patient, consumer satisfaction, or patient satisfaction, or person satisfaction, and the community. If we can put all those factors together as the theme of what we heard today, I think we've accomplished a bunch of good things and good ideas. So, Lila, I leave us with that. We do have a working dinner, and that's going to be at 6:30. It's now 5:40, so you have an opportunity to freshen up, go back to the hotel. The restaurant is not too far from the hotel, I'm told, so we probably can all walk, I think. Thank you all for a very productive day. Really appreciate it, and we'll see each other tomorrow morning.